thank you all for coming. I know that this is probably not what you'd like to be doing on a Friday morning, but we're going to cover some statistics, some introductory material today, and I hope that over the course of the next 4 weeks, you will become a little bit more literate when it comes to statistical methods and their interpretation. My name is Jo Wick. I am an assistant professor in the Department of Biostatistics here at KU Med. My office location is just upstairs on the 5th floor, where the entire Biostatistics department is located. Feel free at any time to contact me by email, and if you have any questions regarding statistics or a design of a study. We do have some support that we provide to university researchers that our Director of Research IT will be talking about briefly this morning before we get into the course. I also wanted to make note that the lectures that we are presenting today will be recorded and posted on our department's website under Events and Lectures. If you have registered for the class, you'll be part of the distribution list, so I will be sending out some materials that I'll talk about at the end of today, along with links to podcasts. I'm going to hand it over briefly to our Director of Research IT, Dinesh. I'm not going to try to pronounce your last name because I'll mess it up.
Thank you, Jo. Good morning, everybody. I'm going to be briefly talking about the overall support and other aspects that we do as part of our Department of Biostatistics and what we give. I guess so.
Just double check. Oh, I did. Okay.
So we'll get into the nitty-gritty pieces. So as a researcher, you guys might be familiar with some of these things to collect data or gather data because one of the major parts to be a successful researcher is to gather the right information so that you can process it at a later time or at the end of or study or research and then be able to publish those numbers. So some of the common tools, I would guess, what researchers use are Fortran, Access Database, Excel files because it's easy, it's available, some of the surveys, some of the other data, electronic data capture tool, which I'll get into details here. And if your research that you're trying to do, if it is more complex, then you would opt for a longitudinal database. So what I mean by longitudinal database is capturing information over a period of time at different time points, like a baseline visit, follow-up, 1, 2, 3, and so on. So I just came up with a workflow here, and what I meant to convey with this workflow is as soon as you get a thought, like you want to write a protocol or you want to do some research. So in this picture, this particular guy here, I would assume it would be one of you guys who were thinking about a new protocol. So as soon as you get a thought, you want to write a protocol, the best approach would be to get in touch with one of our statisticians. We have around 15 faculty members in our department who are familiar with various other, they have various expertise, like some of them do purely research related to pharma. Jo is expert in Bayesian adaptive randomization study designs. So once you get in touch with them, they can help you, guide you in the right direction. We don't want to sit there and, monitor your stuff, but we want to help you go the right path. For examples, there have been, in the past, we have seen researchers do a design, but they do not know what the sample size they want to collect because they're new, they're trying to do something innovative, but the right sample size, or at least an approximate sample size close to right sample size, would be a major win-win to start off your study design. how you would know whether it's the right sample size by looking at the previous data, by looking at the inclusion-exclusion criteria, by looking at the local population that's available for your research. So our statisticians would be able to help you out in coming up with that closest exact number for your study design. That's what I meant by sample size here. And especially, you don't want to be collecting variables or data points that you are not going to be analyzing. So how do you know that? So you want to chart out what's your goal for research, and then our statisticians would help you guide in collecting the right variables that would be used for the analysis. Okay? And randomization. Randomization, this is a common thing that we have noticed. Some of the researchers want to compare two different treatment arms or two different treatments or maybe multiple treatments, and they want to identify which treatment is best. So in that case, we have noticed people want to do that, but they don't have a randomization. If you don't have a randomization, then you can't sample your sample size and you can't assign people in the right group. So you would end up with some bias. So what I meant by bias is you'll have a group that would have a lot of people, and then you might have another group which has very few people. Then the comparison wouldn't be like for apple to apple. It would be like apple to orange or something. So you won't get the right results that you are expecting. So that's where we could help you guys out with the proper randomization, whether it's cluster randomization, whether it's Bayesian, or all the other different types. I'm very naive with those terms. Probably Joe can talk in detail here. And then accrual tracking. So with sometimes what happens is when you start doing research, you have a huge sample size, say for suppose 200. For some reason, you guys lose track, or within 2 years, you're not able to get to 200. There are methods where you can impute stuff from the missing visits or missing patients, and you can get too close to a result what you are wanting to, but not, again, it's not going to be perfect, but that's something that would help you at least reach your goal. Okay. And this is one of our clinical trial management system, which is available for all the KUMC folks, and it's it's supported by the university and the cancer center. Mostly every clinical trial is stored into the system. It's called CRIS, Comprehensive Research Information System. That's the name. It's a third-party tool. It's manufactured or it's been developed by Bellows, a company. It has got all the bells and whistles. Those are listed in the features. Like we have standard forms, different queries, calendars, finance modules, and randomization. So these are some of the forms. The use of these forms, again, it comes back to, in this workflow that I was saying, what variables should be captured? What variables are important for your research? How are you going to know? You can take a look at our standard forms library, which have been used for over the period of time, like for the last 5 years. We have all the forms that have been used by cancer researchers, by neurology researchers, by cardio. Various forms and variables are in there. So we would be more than happy to share that information with you. And you can go through and find out what were the variables that were captured during last few years and how they turned out to be very important for their research. Again, those variables will change depending upon what's your end goal, what's your primary analysis in your research. So, but then this would be a starting point for you guys to think about your forthcoming research projects that you are thinking. Again, randomization within the software. Once we design the randomization, once you come up with what kind of randomization is appropriate for your study, our statistician will generate a randomization table, and that will be loaded into the system, and system will automatically randomize the patient once the patient is qualified based upon the inclusion-exclusion criteria. And you can see how the randomization number gets generated automatically. Whatever treatment arm they belong to, the treatment arm will pop up, and say for suppose it's a pharma study, then the the pharmacy, KUMC pharmacy, will get a notification saying that this particular patient has been randomized to this arm, so they will dispense this particular drug. Okay. And some of the reports and notification, there are features within the system that allows you to automate some of the reports and notification. Just like this, it's more like a scheduling feature where you know how many patients are going to be due in the next visit. So I'm not going to open that Excel file. It's got some PHI in it, but I'm just showing you the overall email notice. So you can see the lady here on this email, Trisha Snow, is a study coordinator. She gets the list upfront on every Sunday night with the list of all the patients who are due for their follow-up visit in the next week. So in the next 7 days, this Excel file has all the names of the patients who are going to be due for their follow-up visit. And similarly, drug refill, if it is a randomization study and if the drug for those patients if the patients are going to run out of the drugs and their drugs needs to be refilled, then the pharmacy gets a list saying that, okay, these folks are going to run out of the drugs. They're part of this research, so please refill those drugs for these patients. And the information would be stored in this Excel file. There's also another tool that we support, which is EDC, Electronic Data Capture Tool. It's called Open Clinica, and the features of this are limited. The reason being it's an electronic data capture tool, and there is a difference, there is a thin difference between electronic data capture tool versus a clinical trial management tool. A clinical trial management tool is purely focused towards doing research, towards clinical trials. Electronic data capture tool could be used for multiple reasons, like to improve quality in a particular process or quality management, etc., etc. So there have been some clinical trials which have been conducted using Open Clinica in the past couple of years. This is a new tool that we launched a couple of years ago, but it's got some great features and potential for usage. So let us know if you're interested. And last but not least, I would like to let you guys know that you can visit our Department of Biostatistics website, and you can contact us. There's a registration link right at the bottom. Right, this one. So once you fill this out, our project manager, Megan, she'll get in touch with you, and if you guys need a demo or if you guys want to explore the option of looking into the standard forms, standard reports, and things like that, we are more than happy to help you guys out. Any questions? Okay. Thank you.
Thanks, Dinesh. Before I get started on the actual course content, I want to make sure that if any of you have come from off campus and need your parking validated, I have the stamp up here, so just come see me at the podium whenever we're done. I can take care of that for you. The objectives of the course have not really shifted over time, but the course content this year is going to be just a little bit different. The overall purpose of this class is just to help improve statistical literacy among researchers on this campus. So it's not to make you a statistician or to make you magically walk out of here and be able to do really sophisticated modeling techniques. But I will show you a lot of the more commonly used simple methods for doing data analysis in a free tool that I think is much more user-friendly than something maybe some other things that you've been working with in the past. So again, I want to make sure that we understand that I'm trying to improve your literacy, your ability to understand whenever you're reading a manuscript or some kind of publication, what they mean by the p-value. What do they mean by the confidence interval? What do they mean by an odds ratio or a hazard ratio? That's really what the objective of this class is. Based on some feedback from previous years, there are a subset of people who are also interested in learning how to do some of these simple techniques. So beginning next Friday, I will be demonstrating an actual analysis example for some common methods like t-test, correlation, simple linear regression. And again, it won't be as in-depth as it would be if you were actually taking a real class in that method, but it will at least demonstrate some of the intricacies of pulling in the data, visualizing the data, doing the analysis and seeing what the output looks like, and then more of a discussion around what that output actually means. If you all have any questions at any time, please make sure you stop me. I don't want to just stand up here and lecture. If that's what you want, I can do that, but I also would like to encourage questions or discussion around any of these concepts as we go through them. Formally, the course objectives are 4. Understand the role of statistics in the scientific process, and in particular, how it plays a role in evidence-based practice in medicine. Understand the features, strengths, and limitations of different types of studies that we do in biomedical research, and how those tie to interpretation of results. Distinguish between association and causation. I think that this is obviously directly linked to the type of study that you're doing, the type of analysis that you're doing, and also understanding the roles of chance, bias, and confounding in the evaluation of research. I'm not sure what that noise is. And then the ways that we can try to minimize their impact on the results of our own research. Today we're going to do a brief introduction to statistics. We're going to learn a little bit more about the language. How many of you have ever had a class in statistics, whether undergrad or graduate? So probably like a traditional methods course where you start out talking about basic concepts of probability, then you get into the different types of distributions of data. Then you maybe talk about chi-square tests, contingency tables, t-tests, ANOVA, that kind of course. We'll cover all of those methods, but again, at a very high level today. We're going to reintroduce some of the language behind statistics, and at the very end of today's lecture, I'm going to introduce a computing software that's free and accessible through the internet called RStudio. Is anyone here familiar with RStudio? A few people. So that's what I'm going to be using for demonstration purposes. It's free. Everyone can use it. It has some fantastic capabilities for basic analyses, some fantastic capabilities for visualizing data. The graphics are state-of-the-art. And it's also set up in a way that it overcomes a little bit of the challenges when it comes to programming, because it is actually a programming language, but it does a lot of autofill for you, so it kind of helps you along a little bit. The next 3 weeks will then focus on methods. So we'll touch on how to critically evaluate the literature on July 15th. We'll talk about, again, some of the limitations of different types of study designs, what kinds of conclusions or what strength of conclusions are associated with different types of designs. And then begin really, I think, at that point, talking about different types of analytical methods that we can use. And then the remaining parts of the course will be focused on different... if there's someone online that has their microphone on, could you please mute it? I believe that that's probably what we're hearing. Just in case. Thank you. If you have a question, though, please feel free to chime in. Okay, that makes sense now. So we'll look at how do we analyze data related to a question about associations between two categorical variables. Like, is gender associated with response to treatment? That's a category, male, female, and a response, yes, no. We'll look at things that may result in us needing to use a t-test, regression, survival analysis, those kinds of things. And then at the end of the course, I will send out a link for an evaluation through REDCap. And I hope you'll give us some feedback to help us improve for next year. Are there any questions at this point? So let's just learn to speak the language, or remind ourselves how to speak the language of statistics. Statistics, in the past, I have defined as a set of tools to facilitate decision-making in the presence of uncertainty. But I want to take a step back and retract that definition. Statistics is a science. We are a field I don't know what just happened there. We're a field that is trained to facilitate decision-making. We're based in mathematics, but we are really an applied field. Some of the questions that we help address, maybe someone wants to predict a patient's long-term chances of successfully quitting smoking when their therapy includes both nicotine replacement and varenicline. We want to estimate the prevalence of obesity in the United States, so some kind of observational study, or estimate the survival of patients after transcatheter valve-in-valve implantation inside failed surgical valves. Let me make sure that we don't have an issue with Adobe Connect. Looks like we're still okay. I'm not sure what happened. Whenever you're reading a manuscript or a publication, this is from JAMA in 2014, you get these big tables with a lot of information in them. So for instance, we have a per protocol analysis. If you aren't familiar with the different types of analyses you can do to experimental data, you may not know what a per protocol analysis versus an intent to treat analysis means and how they differ, or what their purposes and strengths and weaknesses are. We'll talk about that during this course. You might not know what multiple imputation means. Frequencies, okay, we do have a problem with Adobe Connect. Okay, I'm going to, give me just a moment. It looks like Adobe Connect kicked us out of the screen sharing. That was odd. Point prevalence abstinence rates, continuous abstinence. What are these numbers here? Frequencies and percentages. What does the p-value mean? What's an odds ratio? So we're going to talk a little bit about how to interpret these findings in a pragmatic way. We're not going to really dive into the mathematics behind them. Here's another example of a big table where we have some crude and age-adjusted rates. What does that mean for different racial and ethnic groups? And confidence intervals. What are the interpretations of these confidence intervals in context of the study? This is a very common question that I get asked. What does this graph mean? This is a cumulative, kind of a measure of cumulative risk of an event occurring. And these graphs are not necessarily straightforward unless you understand explicitly what the x-axis and the y-axis represents, so that it really is visualizing a treatment effect here in terms of not only the timing of a failure occurring, but the rate at which it's occurring over time. And it gives you a visual comparison of different types of valves and their risk of failure. Here's another example of that. So again, scientists primarily call on statistical inference to help model uncertainty inherent in your investigation. If we knew the real phenomenon producing a result, we wouldn't need statistics. Statistics allows us to link something that is latent or unobservable to what we actually observe in order to get a better idea of what's actually going on. So this is just a little graph showing how we really can't see reality. It's something, but we do have evidence in the form of data that we either sample from reality or we generate through an experiment. And we can summarize it using numbers and pictures. And this information, this empirical evidence, depending on how it was generated, can give us an idea about what reality looks like. Here's an example just to kind of get us thinking about the ways in which reality can mess up our inferences. Suppose that you're concerned about the difficulties that some people are having in conceiving. Based on your observation treating these women or these couples, you think that women exposed to a particular toxin in their workplace may be having greater difficulty becoming pregnant than those who are not exposed to that toxin. So you decide you're going to conduct a small pilot study of these women and basically measure whether they were exposed to the toxin and then how long it took them to conceive. As a statistician, I am trained to associate or assign variation in an outcome to different things, different possible things that could have caused that variation to occur. So we're hypothesizing that this toxin is causing some variation. People who are exposed have a longer time, have prolonged time to conception than people who are not. But there are other sources of variation that would affect a woman's time to conception. There's natural variability in terms of her genetic makeup, her other prior risk factors. There may be hormonal issues. There may be other health-related issues that we are not measuring. So there's natural variability from person to person that can be attributed to many causes aside from that toxin. Once we get the data, though, what we hope to see is that to support our hypothesis is that females with the greatest exposure to the toxin actually do have the most difficulty getting pregnant. Their time to conception is longer than those without the exposure. What if, though, women who smoke while they're pregnant reduce the chances that their daughters will be able to conceive? This is actually a known finding, but we didn't measure this. And what if, by chance, now this obviously is a contrived example, what if by chance this factor is confounded with our factor of interest? And what I mean by that is that women who are exposed to the toxin also have been exposed to, had mothers who smoked while they were pregnant with them at higher rates than the other group. If you didn't record this lurking variable and you didn't know whether or not these females had mothers who smoked when they were pregnant, you may actually draw the wrong conclusion about the toxin. So we have different things impacting the fertility of these women in your study. Natural variability, that we're just going to call noise, the toxins of interest, and then these lurking risk factors that we may or may not even know about, that we may or may not even be measuring. So what could happen to a study in this case? Suppose we have taken our women and we've classified them into groups, those who were exposed to the toxin and those who were unexposed to the toxin. And the question is, if we have found that the time to conceive is prolonged in those who are exposed to toxin relative to those who are unexposed to toxin, the question is it attributed to the effect or the exposure of interest or to some other lurking exposure that we may or may not know about? If, in fact, we have this breakdown where the majority of women who are unexposed to the toxin were also unexposed to this other risk factor, and the people who were exposed to the risk factor of interest but also exposed to another risk factor that could be causing variation in our response, then we may make an incorrect decision that this exposure of interest, the one that we're actually recording, is the thing that's causing the time to conception issue. This is what's called a type 1 error. A type 1 error is when we conclude that there is an association or a cause or a difference or a change when in fact there isn't. And this is a very common problem with what are called observational studies. Observational studies are studies where randomization is not used. So what we're doing here is we are observing the natural exposure patterns of women, not taking into account that there may be other risk factors associated with both that exposure of interest and the outcome of interest that could be causing the relationship There may be absolutely no scientific link, even if there is an association. This is why when we have observational studies, we don't conclude causation. We don't have a study design here that minimizes bias enough. Bias that could be due to lurking variables in order for us to generate data that's that strong. You have to then have a randomized controlled trial, preferably one that's blinded. So this, of course, this is what bias means. Bias means systematic deviations in an effect that would make us conclude something incorrect. What if we had the opposite, though? What if this toxin of interest actually is causing a problem? We still have the same study, the same observational study. Women's natural exposure to this toxin is being recorded. But now, instead of seeing that difference, we have actually seen no difference in their time to conceive. And the reason behind this, let's assume we know the truth here, is because we have this lurking variable, again, smoking exposure, which is also a risk factor for having fertility issues later in life. We have this lurking variable that's causing additional variation in our outcome. It's basically making our data more noisy. So it reduces our ability to detect a signal between the exposure of interest and the time to conception measure. So this kind of situation can also be caused by bias. Bias in the form of noise, basically, where you're not getting systematic deviations in one direction that may make you think that there's a relationship when there isn't. What you're getting is deviations in all directions of your response, and the result is making it too noisy to really see anything that's actually there. And this is what's called a type 2 error. A type 2 error is concluding that there's not an association when in fact there is. And again, these are major problems with observational studies where randomization is not used. The purpose of randomization is to minimize the chances of this actually happening. And we'll see that primarily in the next set of lectures. So conclusions, when it comes to scientific investigation, always come with some amount of uncertainty. Statistical methods allow us to try to quantify that uncertainty. We quantify uncertainty using things like levels of confidence for confidence intervals, 95% confident versus 90% versus 99%. Standard errors of estimates, which describe how reliable and stable our mean is that's been generated from that sample. If the standard error is very big, this is not a very reliable, a very good or quality estimate of the average of the population. P-values. We're going to talk a lot about p-values. I'm sure, have you all been reading about the p-value controversy that's been in the literature for at least the last year? It's been all over the place. The American Statistical Association, it's been such a hot topic the last couple of years that the ASA, the American Statistical Association, which is like the AMA or the ADA for medical professionals and dental professionals, released a policy statement on p-values. We're going to talk about that policy statement, what a p-value is telling us and what it's not telling us. We're not really going to dive too much into the interpretation, but just how do we use them properly? Because unfortunately, they've become a crutch for a lot of scientific investigations. And then, of course, proper interpretation is a crucial part of the statistical sciences, because we try to link evidence, empirical data, back to the context that generated that data to make sure that we're properly interpreting results as best we can in light of the context that produced the results. Let's touch briefly on evidence-based medicine. Evidence-based practice in medicine involves two things. It involves gathering evidence in the form of scientific data and applying the scientific method to inform practice. That's it. It's pretty straightforward, right? It's actually very difficult, in my opinion, to implement simply because we sometimes fail to acknowledge that in addition to the objective pieces of evidence-based practice, there is a subjective component as well, and that's that informed decision-making on behalf of a physician or any other kind of medical professional. This is actually evidence-based practice. You can fill in any term here. Evidence-based practice in statistics involves gathering evidence in the form of scientific data and applying the scientific method to inform practice. I use evidence-based statistics whenever I decide which method to use for an analysis. I also have to acknowledge that another statistician who is just as well trained and just as experienced as me may come to a different conclusion, and I think we have to acknowledge that in anywhere where evidence-based practice is applied. But the critical components are understanding what evidence is available, understanding the strength of the different sources of evidence, compiling it, and making an informed decision using the scientific method. There are different strengths of evidence. Scientific evidence, by definition, is something that's observed. It's empirical. It was gathered in accordance to the scientific method, which serves to support or counter a theory or a hypothesis. The different levels of scientific evidence increase in their strength. Type 1 is basically naturalistic observation. It's like an epidemiological study. So I'm going to go out and I'm going to observe a population in their natural state and just see what's happening, see if there are associations or patterns. There are a lot of problems with that evidence for the reason I just demonstrated in the example on fertility, because there are other things that could be causing associations that you observe that you're not measuring or you don't even know about. So you could never really get the strength of evidence that would result from what's called type 2 evidence, which is intervention-based. Intervention-based is kind of a misnomer. What we mean here really is experimental, true experimental data, where you are exerting control over the assignment of treatment or the assignment over your experimental conditions, preferably through some kind of randomization, because what that does is it reduces the chances that you're going to have those confounding variables or other sources of bias that could cause systematic deviations in your outcome of interest and cause you to come to an incorrect conclusion, either make a type 1 error or a type 2 error. Intervention-based data is very nice because, well, not in human data. Let's talk about animal data for a moment. Animal data from clinical type applications where you're randomly assigning animals to conditions and you can exert complete control over the experimental situation, gives you really nice, clean data. Clinical trials are similar to that. Whenever you are running a clinical trial, you exert very tight control over who has access as a patient to be on study through your inclusion and exclusion criteria. You have really tight control in some situations over how treatment is administered and how the outcome is recorded. You have really tight control over what other therapies can actually take place while they're being treated. So you get really clean data. You get what's called a measure of the efficacy of a treatment. Does anyone know what the difference between efficacy and effectiveness is? They are not the same thing. Someone wants to talk? Can you? No? Okay. Efficacy is when you see a benefit to treatment from intervention-based data, intervention-based evidence, where you have given the treatment ideal conditions to work. You've given it the right population, you've administered it in the appropriate way, you've had tight control over other things that could be going on while treatment is being administered, and then you see a result. Effectiveness is how that treatment works in the real world. And we all know that sometimes it works very differently in a real world setting because that tight control is no longer there. People are taking another med with this med, or they're skipping doses, or they're smoking while they're taking the medication, or maybe their disease is not the one that's necessarily being targeted by that treatment. So the effectiveness is usually not as high or as good as the, I've already forgotten the word. Thank you, efficacy. Sorry. I have an infant at home, so my brain is, sometimes it spins its wheels. So that's the difference here. Intervention-based data is ideal. That's usually what we work with, but we also have to understand that the effects that we see from that data may not translate into the real world, and that's why often you see subsequent studies, subsequent larger studies, end up with effects that are not as big in these smaller, more tightly controlled studies. The key here, though, is that evidence-based practices are those that have been rigorously investigated through scientific inquiry and found to be superior in some way to other known alternatives. So implementing those results in a high likelihood of successful patient outcomes and a much more efficient use of healthcare resources. We don't need to review the scientific method, right? Observe, revise, experiment. It's a cyclical process. The point I want to make here is that very often, whenever I meet with an investigator, they come to me and they want to do okay, well, there's two situations here that I get. I get people who want to do a bunch of really small studies and never want to progress beyond that. That's not good. Why is that not good? Because you're not moving the scientific method forward. You're not pushing forward the line of inquiry. Unless, of course, you do a pilot study, a small study, and it comes to a dead end. Then you have to kind of change direction and do another pilot in a different direction. You should always be building on what is already known, and sometimes that can be difficult because we're getting better at it, I think, as a scientific community about putting our results out there and what we're doing through this initiative called Reproducible Research. Has everyone seen the Science article on reproducible research in terms of pre-registering your studies so everyone knows you're doing it while you're doing it? So I'm not going to go and try to do the same study that you're doing because I can see that you're doing, and I'll wait for what you're going to see. And for people to also be more transparent, not necessarily data sharing data because there are a lot of issues around that, but sharing your methods, sharing your protocol, sharing your statistics, your analytical code, that kind of thing. The scientific method, we should be adhering to this, I think, a little bit more in terms of the way we approach designing and implementing clinical studies, observing, revising, and experimenting. This is mimicked in clinical evaluation by maybe starting off as a researcher, just observing how your patients are responding to different things that you're trying in the clinic, beginning with kind of a case study. So I'm going to really take a look at these one or two patients who observed, who responded really well and try to figure out what made them respond so well to this treatment that maybe didn't work so well in the past, and then use that information, that evidence to design a research question that can be testable through an experiment, probably a really small one, to gather preliminary evidence, which would then inform my subsequent hypothesis, my subsequent design, and any revisions to the information that I've already collected, run that experiment, generate further data, which could then either allow me to revise my hypothesis and design a new study, or follow the same line of inquiry because it confirmed what I thought, or at least supported what I thought was true, so then I create a larger study to get even more definitive evidence. So this is how the clinical evaluation works. Acknowledging what's known, and figuring out where do we start in the scientific process. Do we start with a pilot? Do we need to start even before that in some kind of basic science situation? The different types of studies that you could select for your research are really dependent upon the strategy that you take to approach a scientific inquiry or a research question really depends on the purpose of your research. And the purpose of your research really depends on what's already known, what's already been done. So if you're at the earliest stages in inquiry about a phenomenon, then you may just want to explore some patterns in data. In this case, you're going to get really ambiguous results because you're doing what's called naturalistic observation, which is kind of that epi bent, or you're doing a case study or case series where you're really focusing on one or two patients and you're mining the heck out of that data. What is going on here? I'm not trying to get p-values out. I'm not trying to get definitive evidence or confirmatory evidence of anything. I just want to see, are there any patterns that are interesting, that are maybe meaningful scientifically, that warrant further investigation. At that point, you may start to try to describe those patterns and classify relationships or classify subjects or populations, and then establish relationships. And then, of course, finally, the ultimate goal is to somehow establish causality of these things. Do we know that X ultimately causes Y, either Y being a positive or a negative patient outcome? So the purpose is linked to the strategy, and the strategy, depending on where you are, could result in ambiguous results, depending on the level of control that you've exerted over the experimental situation. So we have that really tight control in those randomized controlled experiments. We have almost zero control other than who we're actually including in our sample in terms of naturalistic observation. So as you increase control, you decrease the ambiguity and you increase the strength of that scientific evidence. The different types of studies, now this is obviously kind of succinct and limited here. I've got probably the ones that are most commonly applied in biomedical research. Case reports, case series, and cross-sectional studies are what are called descriptive. Their purposes are for description only. I'm not trying to generate p-values. I'm not trying to do hypothesis testing. I want to get preliminary evidence that may allow me to apply for a grant to do an analytic study, a pilot study, like a randomized, some kind of small randomized pilot. These descriptive studies are done either in individuals or populations. We'll talk next time specifically about the different features that would make something a cross-sectional study versus a case control versus a cohort study. But the idea here is, what is the purpose and how is it linked to the design? Analytic studies can be either observational or experimental. So in the previous slide, observational studies are what are called quasi-experiments. You probably have a group of cases and a group of controls, and you want to compare them in some way. The reason it's observational or quasi-experimental is because the cases were cases. You didn't assign them that status. They had the disease whenever you allowed them to join your study because they met the criteria. The controls were healthy controls or whatever kind of control you have. You didn't assign them that status. They came with that status already in place. So again, like the fertility example, there are many, many issues with observational studies, but they serve their purpose when randomization is either not feasible or maybe they are also serving to provide some evidence to facilitate doing a randomized controlled trial. So that's the primary difference between what's called observational or quasi-experimental studies and experimental studies. This right here, oh, I thought I had a gold star here. Randomized controlled trials are the gold standard of scientific evidence, at least in terms of that type 2 intervention-based evidence, because they have exerted full control or as much control as possible over the experimental situation to minimize all kinds of bias. Bias that could result from lurking factors, from self-selection, from observers, from the statistician, those kinds of things, from the patient themselves. Of course, there's a trade-off here. As you increase in complexity and increase in your confidence of the results, you also increase in the resources and the time and the cost it takes to do these studies. Oops. Here's a brief question or a brief example of a quasi-experimental or an observational study where we have 3,000 subjects that were recruited over 2 years. From these subjects, we take blood samples and have them answer a cardiovascular disease risk factor survey. And we're really after what are the different associations here. How does serum total cholesterol vary by the age of a person, their gender, their levels of education, their use of different types of blood pressure medications. And then for those who smoke, are those associations that we see different from those who don't smoke? The outcome here is serum total cholesterol, and there are many different factors that we're looking at, like the blood pressure medication or the smoking status. What are the possible confounders that could affect the outcome, serum total cholesterol, besides, for instance, the blood pressure medication that may cause us to see a link between a particular type of blood pressure med and the serum total cholesterol level? What can affect cholesterol levels? Diet, exercise. Do people who, is it a reasonable assumption to make that if you have a group of 1,500 smokers that they probably don't exercise as much as a group of 1,500 non-smokers? Is that a reasonable assumption? We could check it out. I mean, I would guess that that's probably the relationship. I doubt it would be reversed, but it's possible. So there are things that could be associated with both the risk factor and the outcome that we're not thinking about that could cause us to incorrectly conclude that some kind of medication is increasing serum total cholesterol. I don't know why that this is doing it. I think, there we go. So that's a source of bias. Here's an example of an experiment. Will a new treatment help overweight people with diabetes lose weight? So we have 40 obese adults with type 2 diabetes. We have exerted control over the potential confounder of gender by limiting our sample to 20 males and 20 females, and randomized in a way that we have distributed gender equally across the groups. So we've done some kind of restriction on our randomization because we think that gender could cause bias. We also have implemented this in a double-blind fashion, which means that not only are the patients blind to the type of treatment, but the observer, the person who's measuring whatever clinical outcomes or patient-reported outcomes, does not also have a knowledge of the type of treatment that the patient got. And we have a placebo control in order to measure what is the effect of simply treating a person with type 2 diabetes. What is the effect on weight loss for these individuals? The placebo effect is a well-known effect. Anytime you have human research, human subjects research, it doesn't have to be medicine, it can be any kind of human subjects research. It's just really measuring the power of suggestion. We'll talk more about the placebo effect next week. But the outcome here we're going to look at is weight loss, and we're really interested in comparing the treatment versus placebo. The randomization, there are different ways this experiment has accounted for or tried to minimize bias by exerting control. We've randomized. So randomization's purpose is to hopefully make the treatment groups as closely, as homogeneous, I should say, as homogeneous or as similar as possible in all respects except the thing that you're interested in testing. So they're all the same gender. They are approximately the same age. They all have different socioeconomic status. They all have a similar racial or ethnic diversity in the groups. What other things are associated with? They all have the same types of distribution of levels of activity between the groups, the same history of disease, the same comorbidities. Because we've randomized, we have distributed all of those potential confounders equally across the groups so that the groups are homogeneous with respect to just about anything that you can think of that could cause differences in weight loss, except for the treatment. One gets a placebo, one gets an active treatment, and then when we do a comparison, we're pretty confident that if we see an effect, that it's due to the treatment because they're similar with respect to everything else. And that's not the case when we don't exert control over inclusion and exclusion criteria. We don't exert control over how treatment is assigned, when we don't blind, when we don't have adequate controls. For the remainder of today, let me see how we are on time, because I think that clock is, yeah, we should have plenty of time. For the remainder of today, I'm going to focus primarily on descriptive statistics. So how do we process, summarize, present, and describe data? Before I can do that, we have to talk about data for a second. So in past years, I've spent a lot of time talking about data. I've kind of pared it down. But I think it's important, and it should not be left out, because that's usually one of, well, it is. It's one of the two primary things that we have to account for before we can decide what methods are appropriate. So we have to understand the information in our data and our research question. So we're going to focus today on descriptive statistics. Next week, we will touch on design of experiments, like what are the techniques for planning and conducting experiments, sample size calculation, randomization, blind, study, what are the different types of study designs depending on my question of interest. And then we're going to get into inferential statistics, which is things like t-test and regression and ANOVA, confidence intervals, those kinds of things. So the field, the science of statistics, can really be simplified into three primary areas, at least for an applied statistician. Descriptive statistics are the methods that we use to visualize and describe data that's been generated by some kind of experiment. Design of experiments are all the tools and techniques that we're trained to use to provide scientific data generated from experiments that is valid for addressing a research question. So number one, we make sure that the data that's generated is as valid and reliable, as unbiased, basically, as it can be given the context. We make sure that you have enough data, it's the sample size calculation, and that it's actually linked back to the actual hypothesis that you're testing. And then, of course, inferential statistics are all of those methods that we use to choose between competing theories. Is there a difference or is there not? Is there an increase or is there not? Is there a decrease or is there not? That kind of thing. So that's what inference is doing. We primarily do this through graphical and numerical methods, and estimation and hypothesis testing can be lumped into inferential statistics. So we'll talk about this stuff in the next 3 weeks. I've already talked about most of this. Descriptive statistics, we were just describing and summarizing data. Inferential statistics uses sample data to make conclusions about a broader range of individuals than those who are just observed. And design of experiment includes things like formulation of testable hypotheses based on your root of scientific inquiry, determination of the experimental conditions, the measurements, and any other extraneous lurking conditions that we need to control for or measure, specification of the sample size and what the population is from which they'll be drawn, specification of the procedure for assigning subjects to experimental conditions, and then determination of the analysis that will be performed. This is all those steps for design of experiments. Descriptive statistics, which we're going to focus on today, is, and this is actually true for inferential statistics as well. It's the area of statistics that includes the graphical and numerical summaries of sample data to facilitate decision making. Very often, I get the question, what method should I use? What method should I use? So the question that I ask back is, well, what's your research question? And what kind of data do you have? And what is that data actually telling me? What does the number 1 mean? What does number 5 mean? If there's a change from 1 to 5, what does that mean? Is it meaningful or not? So these are the two questions that I always ask back. What's your research question? What's the type of information being conveyed by the data that you have to address that research question? If you can answer those two things, then we can get you to at least a subset of methods that would be appropriate and determine which one's optimal. So let's focus on, for a moment, the type of information. We'll get to the research question and how that ties in next week. The type of information is linked to the level of measurement of data. Levels of measurement is nothing new. It's actually something that, unfortunately, I was never exposed to in any of my statistics courses. But I think it's so fundamental, that's probably why. For people who want a recipe book, this is a key part of your ingredient. understanding what level of measurement your data falls into. Nominal data is the least informative. Gender. If I code a male as an M and a female as an F in my data set, I have basically classified cases into one of two mutually exclusive classes. That's what a nominal variable does. It just classifies subjects. It doesn't tell me anything about which one is better or worse or bigger or smaller. Because even if that data was represented using numbers, like a 1 and a 0 or a 1 and a 2, the 1 is meaningless. It just means it's different from the other. Ordinal variables are one step up in terms of their level of measurement. They have a little bit more information. Since they have a little bit more information, they're a little bit more sensitive to differences, because the more information you have, the easier it is to see shifts or changes. Ordinal variables not only represent things that are different, but they have some kind of inherent ordering in their categories. For instance, I'm going to give an example of ranking in sports. So you have, right now, I think Wimbledon's going on. Is that still going on? We have like number 1 in the world and number 2 in the world and number 3 in the world. I have no idea who they are right now. But maybe the top 2 in the world are so much better than everybody else that the difference between number 1 and number 2 is not equivalent to the difference between number 2 and number 3. So that there's no what's called equivalence of intervals, which is actually a property of what's called interval data. Interval data has both difference and order and meaningful differences that do not occur in ordinal variables. And then ratio variables are the most meaningful. You can't get any more information than this. You have difference, order, meaningful differences, and meaningful ratios. Meaningful ratios only exist when you have what's called an absolute zero. Can anyone think of something that has an absolute zero, just off the top of your head, where 0 means a total absence of something being measured? Temperature, what kind of temperature?
Kelvin.
Yeah, Kelvin, right. Not Celsius or Fahrenheit, right? What about time? Age? Anything where production, anytime the 0 has real meaning, and it's not an arbitrary location on an axis, you can make statements about ratios, like this took twice as long, or this produced twice as much, that kind of thing. In practice, we very rarely refer to data by these names. We often kind of lump them together and just acknowledge the fact that sometimes there's order and sometimes there's not. Sometimes there's an absolute 0 and sometimes there's not. We tend to put them into these two categories that are called qualitative versus quantitative data, categorical versus quantitative, or categorical versus numeric, discrete versus continuous. But this is a nice way of at least establishing what kind of information you actually have in your data, and probably even more important, what kind of information you don't have. It dictates what you can say about it. Any questions about this? I'm going to give a couple of examples of each kind just to make sure. Obviously, information increases. Ratio variables have all the properties of the other three. Interval variables have all the properties of ordinal and nominal. Ordinal have all the properties of nominal, and so forth and so on. The amount of information included in a data point increases as you move up this measurement scale. Ratio data at the very top, 6 is different from 7. 6 is also smaller than 7. 6 and 7, the difference between those two, if I make a shift between 6 and 7, that shift is identical to the shift between 101 and 102 or anywhere else on the scale that it could occur. So there's a meaningful difference. If you have an ordinal variable, we still may talk about differences, but those differences are meaningless. The direction of the change may be meaningful, but the magnitude of the change is meaningless. That's a mistake that's very commonly made with ordinal data. And then, of course, the 0, the absolute 0, which indicates a lack of what's being measured. An example, length of stay. If I have a data set where I'm looking at the length of stay for readmissions for patients with chronic heart failure, if someone was never readmitted, their length of stay is 0, and that's meaningful. That means they had no time in the hospital. The only distinction between this variable and all others is that this is the only kind of data where you can make ratio statements. You can talk about meaningful changes in terms of their ratio. Person A took twice as long to complete a task as person B. Tumor volume at follow-up is half that was seen at baseline. Some examples of this: age, birth weight, tumor size, follow-up time, length of stay, time to complete a task, duration of survival, dose administered. The 0 doesn't have to be a feasible value for the outcome for it to still have meaning. So for instance, you would never have a birth weight of 0, but that would indicate a total lack of the measurement. So birth weight is still a ratio variable. Interval data, the only thing that you take away now is the ability to make ratio statements. You would never say 60 degrees Fahrenheit is twice as hot as 30 degrees Fahrenheit. In Kansas City, today it's, this happens, I guess, sometimes in the spring, right? Today it's 60 degrees. Yesterday it was 45 degrees. We would never talk about the fractional increase in the temperature from yesterday to today. Or it's 60 degrees in Kansas City and it's 30 degrees in Omaha, Nebraska. It's twice as hot here. That doesn't make any sense, but we can say it's 30 degrees hotter. So there's a meaningful difference, but not a meaningful ratio. Temperature and dates are examples of that. The reason dates are not ratio data is because there's technically, unless you have, or if you're talking about the beginning of the universe, there's really no 0 on that time scale. Ordinal data, remove that difference, that meaningful difference, meaningful shifts. You can no longer talk about those. You can't say on Likert scale data anything about how things change meaningfully. You can talk about that there was an increase or a decrease. One is higher or lower than the other, but you can't talk about whether or not the difference itself seen, if you have two variables and you saw a shift of 4 in one and a shift of 4 in the other, those may have two different meanings because the intervals are no longer equivalent. The easiest one I can think of is not really a biomedical example, it's ranking in sports. So I gave the Wimbledon example. In the NBA is a really hot topic right now. Let's think about Cleveland and Golden State. For those of you who follow the NBA, Golden State just got Kevin Durant. And those are the two that were in the finals this year. Probably next year we'll see them in the finals again. And they're probably much better. I don't know the rest of the NBA. I only know that because my husband's a big NBA fan. The rest of them are not as competitive because they don't have the superstars. So number 1 and number 2, there may be no difference. Number 2 to number 3, there may be a huge difference. So the intervals no longer have meaning. There's no information there. Some other examples include survey questions that are Likert scale. So a lot of the patient-reported outcomes in terms of pain or quality of life it's meaningful in terms of 5 is better than 2, but how much better? We don't know because perception of differences could be different for different patients. The highest level of education achieved is also interval data because it could be if you completed some of the bachelor's degree but not all of it and you're thrown into a class, your difference between a high school educated person in terms of your level of education may be very different than someone else who has technically been classified the same as you. Tumor response, a lot of the, for those of you who are cancer researchers, tumor response is a ordinal measure of efficacy because we classify patients' responses to treatment into categories, and the categories are ordered, but a patient who is a complete responder, we may have 2 patients who are complete responders and 2 patients who are partial responders, but the difference between those may not be the same because one may be on the high end of the range in order to qualify for complete, one may be on the low end of the range, vice versa. And of course, nominal data, you're just classifying subjects into categories. ID numbers or classification. Pass-fail response. Yes, they responded. No, they didn't. Gender, race, ethnicity, disease type, unless there's some kind of severity assigned to it. Those are all nominal variables. And the reason I spend a little bit of time on this is because this is a key aspect of decision making. You have to have this information in order to decide how you're going to describe the data, how you're going to analyze the data. More mathematical operations and relations, more sophisticated statistical methods can be performed on that interval and ratio data because it has more information in it. It's mathematically tractable. The number and changes have meaning, whereas ordinal and nominal data don't have enough information in order to define, for instance, the sample mean. You can't define the sample mean of gender. It just doesn't make sense. Methods for categorical data, that nominal and ordinal data, on the flip side, have less restrictive assumptions. So you can use these methods on just about any data that you have, but unfortunately, because you have less information, you also have less sensitivity to any changes that may have been occurring in your groups or any differences that may be occurring in your patients. In general, it's desirable to collect data on variables that have higher information content, but it's not always feasible. Any questions about, okay, categorical data, the way we describe it, we use frequencies, percents, proportions, modes. Medians are only appropriate when you have order. We also visualize them using bar charts, mosaic plots, pie charts, and variations of those. Numeric data, which is the quantitative, the interval, and ratio data, we tend to describe three aspects of a single numeric variable. We describe its center, its spread, and the shape of its distribution. The center we describe using averages like the mean, the median, or the mode. Typically the mean, but also the median in some circumstances. We describe the spread using the standard deviation or the range. And again, which of those we choose is dictated by really the shape, this last one here, of the data. The shape is it symmetric? Is it a bell-shaped curve? Is it skewed, meaning, you know, it looks like someone grabbed this one tail and strung it out in one direction or the other? Do you have highly unusual observations, outliers? Kurtosis talks about how fat or skinny the tails of the distributions are, which is also a measure of how similar observations are. And then modality. What I mean by modality, that's probably not a very good word. I just mean, is it bimodal? Is there a single hump? Are there multiple humps? That's a very technical term. And then histograms, box plots, and scatter plots are really common graphical tools for visualizing numeric data because they not only give us an idea of the shape, but they give us an idea of the location, the center, and the spread. Box plots are really useful for comparing numeric data across groups, and scatter plots are really good for looking at the pattern of association between multiple numeric outcomes. Here's just a quick example showing a table describing the association between two categorical variables. If you had this kind of experimental situation or this kind of data with this kind of research question, you would use what's called a chi-square test because you're interested in how does nearsightedness, how is nearsightedness associated with patterns of light for children at night. So here we have 479 children. We've got some data here that shows that children who slept with a nightlight or in a fully lit room before the age of 2 ended up later on having a higher incidence of nearsightedness later in childhood. One of the things I want to demonstrate here is, well, you really can't see a pattern in the table unless you really look for it. So if there's a way to visualize your data using a graph, an effective picture, always pick that or produce it in addition to a table of the results. A picture is worth 1,000 words. I think a picture is worth 1,000 tables and even 1,000 words in your narrative as well, because if you have an effective graphic, an effective visualization of your data, it can tell the story without you saying a word. It's not very clear here that there's a pattern, but there actually is. I'm going to skip through that. And here's an example of what's called a clustered bar chart. We're clustering based on one of the categorical variables. In this case, it's the amount of light they slept in. And then we're looking at the distribution of nearsightedness later in childhood for each of those subgroups. And I believe I made this graph. It looks like this is on a percent scale. So 90% of those who had no light before the age of 2 had no nearsightedness later in childhood, but that you can see that that percentage is decreasing as the amount of light increases. That's probably the pattern. And then the sum is also increasing as the amount of light increases. So visually, it's probably a little bit easier to interpret than the table was before, because we see this obvious pattern of that red bar decreasing and the pattern of the yellow increasing. This is obviously an observational study, so let's go back and reiterate some of the concepts of a quasi-experiment. What we find here, the conclusion is the evidence is moderately strong, but it's not definitive of a cause and effect relationship between the amount of sleep time light and nearsightedness. We do see an association, a positive association, but it doesn't show causality because there may be a lurking factor, a confounding, or a nuisance factor. Those are all terms that really mean the same thing, that isn't considered or measured. And it could come down to genetics. Here's an alternative hypothesis to our hypothesis that the sleep time light is increasing nearsightedness. Perhaps children whose parents have the condition are more likely to suffer from it themselves. So it's a genetic thing as opposed to an environment thing. Because it's also possible that those parents are more likely to provide light for themselves in addition to their children while they're sleeping. So this thing demonstrates one part of, I think, the scientific process that needs to be highlighted during this lecture series, and that's the concept of hypothesis. It's funny. It's called, who in here knows how to pronounce this word? Is it myopia? Myopia? Okay, I want to make sure I'm saying it right. It's called hypothesis myopia, ironically. It means we have tunnel vision. We have, and this is true, this is human nature. We don't just do it in scientific investigation. We do it when we argue with our spouse about which way to take whenever you're visiting your parents, how to raise your kids. We come to the table with preconceived notions about what's actually happening. And we try to make the evidence fit our preconceived notions. That's why blinding is so important, and having rigorous experimental controls is important. These are things that we may not even know that we're doing. So it's all about perspective here. Hypothesis myopia is the fact that very often we come in with preconceived notions about what the truth is, and we try to find evidence for that truth. In order to fix that problem, which is rampant, I think, not only in science, but in all other aspects of human life, we have to take a step back and acknowledge other possible explanations. In our case, that would be an alternative hypothesis, an alternative explanation for what we're seeing, and investigate those routes as well. Investigate those models. Make sure that they're not tenable, that they don't stand. If they have just as high likelihood of being the truth as yours, then that tells you something about the strength of your evidence. So I encourage you, if you have time and you're interested, just do a really quick Google search on hypothesis myopia. There's a research center, a whole division research center out on the West Coast that is doing what's called meta-research. They're doing research about research. What are the flaws that we have as a community and how can we fix them? And hypothesis myopia is one of the things they talk about. They give strategies for how to overcome that. It's basically changing the way that we approach things scientifically. Here's another example of describing categorical data. We want to know for different doses of a particular drug, and notice that we have a placebo here, a control, what is the pattern of nausea as dose increases? We can visualize it with a table using frequencies. We can visualize it with again a clustered bar chart where we have we define the axis by one of the variables, and then we have bar charts that represent the other variables. So for those with nausea, what's the pattern? Those with no nausea, what's the dosing pattern? This is an example of an ineffective graph. I can't tell what's even going on here. Number one, the problem is we have different sample sizes for nausea, no nausea. Number two, I think that the classification should be reversed. We should look at doses and how many had nausea and how many didn't. Here's a little bit better representation. I still don't think it's ideal. I actually pulled this from a presentation that was given on this data. But what you can see is that for red, 0 milligrams, 100% of them were classified as not having nausea. And that percent within a group classified as not having nausea is decreasing, or the percent having nausea is increasing as dose increases. The only difference is we do see a slight dip here, but again, we're talking about samples of size 9, 11, 13, and 14. So that's probably attributed to the fact that we have really small samples, so there's sampling variation in our estimate of the rate of nausea or the prevalence of nausea for these doses. When you have unequal sample sizes, it's better to use a percent rather than a frequency. And I would say if you have an obvious independent variable like dose, that should define your axis and then allow your dependent variable to define the bars. It would be I think, much more of an effective tool than what we have here, even though this is better than what we saw on the previous slide. Other things that you can do, bar charts without clustering. Let's just look at the distribution of frequencies or percentages of our sample for their race or their, this is actually a horrible projection of that. This is the different race or ethnicity classifications. It's just taking this table and making it into a graph. This is also a pie chart. You don't see a lot of these. There are issues with pie charts, but we won't get into those because I'm not going to use them in the remainder of the class, but you tend to not see these. Bar charts tend to be the predominant, or a mosaic plot, which I'll show next week. Here's an example of a visualization of a continuous outcome. This continuous outcome, which is a ratio variable, it's survival, time from some predefined baseline until death for patients in a study. This is simply a histogram. What I do want to point out is that there's some subtleties here about the differences between a bar chart. Notice the spacing between the bars. Here we have no spacing. That is a subtle way of indicating that there's continuity, that people can actually have a time to death at any point on the scale, whereas here there's discreteness in the data. That's really the defining feature between a bar chart and a histogram. Here, quickly, we could see several features. Actually, we can see all the features of this information, of this data, in terms of patterns that would not be readily available to us if we were just to use numbers, like the mean or the range. Here we see the minimum value, the maximum value. We see where most people fell in terms of their survival. We see the most frequently occurring value and kind of the average. We also see that there are a few people who had much longer survival time than the majority. So we get an idea of the shape get an idea of the center and the spread of the data, overall patterns, much more quickly than we would in a table. Another way of representing numeric data is through box plots. I would encourage you to use box plots as opposed to histograms when you have a numeric value that you're trying to compare between different conditions, different groups. So here we have a really effective representation of tooth growth for two different supplements, the yellow and the green, at 3 different dose levels, 0.5, 1, and 0.2. Now these are not really informative axes. But what we can see is an increased pattern, right? An increasing association between dosing level and tooth growth for both this supplement and this supplement. And we can also see that at these lower doses, this other supplement appears to result in higher overall tooth growth than the other, both at the 0.5 and the 1. It's not, we don't see that in this final higher dose level. Different statistics, numerical statistics that we can use to describe the center of a data are the mean, the median, and the mode. I want to talk briefly about the evidence-based process of selecting which one's most appropriate or most informative depending on the context. The mode is just the peak. What's the most frequently occurring value in the data set? This is really useful when you have categorical data. Do we have mainly females or they're males? Do we have mainly African Americans or are they primarily Caucasians in our sample? The problem with the mode is that it has very low sampling stability. What I mean by that is that if I were to do an experiment of 100 people and record the most frequently let's say I record the mode of their BMI, the most frequently occurring BMI in my sample, my experiment, and you were to do the same study in the same population with the same number of people, the chances are my mode is going to be pretty different than your mode. It's not very stable from sample to sample. So that's why it's not a really good measure of the center of data. Here is just a graphical demonstration of the mode. Here's a graphical demonstration of the mode for a categorical variable. So it can be defined on either continuous or discrete data. The median is a little bit better, actually a lot better than the mode. It now is a measure that's appropriate when you have ordinal variables. You can describe the median response on the pain scale. And if the median is different in this group than it was in that group. It is simply the middle value of the data. So you take the data and you order it from smallest to largest, and you pick the data point that cuts the sample in half, and that's your median. It's appropriate for numeric data, like interval and ratio data, when you have skewness. And the reason it's appropriate, more appropriate than the mean when you have skewness or highly unusual observations, is because it's not affected by skewness. It's not affected by outliers. It doesn't take into account the actual magnitude or size of the observation, the raw data. It only looks at the relative ordering of the observations. The other problem on the flip side is it has low sampling stability. So again, from sample to sample, it tends to vary more. So it's not a really reliable estimate of the average. But it should be used instead of the mean when you have skewed data or a few unusual observations. This is an example of why we would choose the median over the mean. If we have a set of observations on 4 patients and their outcomes are 1, 2, 2, and 4, and we calculate the median to describe this data set, we would get a number 2, because that's a 2 divides these in half. Unfortunately, data entry errors occur a lot, and the person who is entering the data for me to analyze entered a 9 instead of a 4 for this last observation. If I'm still using the median to describe this, it remains unchanged, which means it's a robust measure of the central tendency of this data set. And I would, as a statistician, recognize that this 9 Number one is an outlier. If I were to plot this in a larger sample, if I had a value that was that different from the core, I would probably choose the median because the mean would be skewed. Here's a graphical representation of where the median would fall on an approximately, on a skewed distribution. It would be just a little bit to the right of the mode in this case. And then finally, probably the most commonly used method is the mean. This is it has a formula, a mathematical formula where you actually feed the data in, the raw values of the data, and you get a numeric value back out. It has a physical interpretation, which we won't get into. It's the center of gravity of the distribution. So if you think of your data as a pile of dirt on a single axle trailer, the mean is where that axle needs to be to balance it out. It's the axle, what's it called, a fulcrum for a seesaw. That's the mean. The mean, if you put a heavy person on one side and a person that's not as heavy on the other side, where can you put that to balance them out? So that's where the mean is. That's a physical meaning of it. That's why if you have dirt all on one side of the trailer, you can't use the mean to describe the center because it's pulled toward the heavier end of the distribution, or it's pulled away from the heavier end and is values that are further away have more impact on the mean than those that are closer together. It does have, though, good sampling stability. So if we were to do studies on the same population with the same number of subjects and measure the same thing, our means are likely to be more similar than perhaps our medians or our modes. So it varies the least from sample to sample, implying that it's better suited for making inferences about populations, more reliable. But it is, unfortunately, sensitive to skewness and extreme values. And then we go back to this example where we had the median that was unchanged by this unusual observation or this error, this data entry error, but the mean is impacted. It goes from 2.25 to 3.5. It is pulled slightly toward that higher value. So we have to be careful and make a decision about whether it's an appropriate metric when we have some unusual observations that may bias this measure of central tendency if we're trying to report it as the average of our data. And here is where the mean would be located in a skewed distribution. Notice it's pulled away from the center of the data. It has to balance out the stuff right here, even though the core of the data is over here. Variability, measures of variability have the same issues. There are robust measures, and then there are sensitive measures. So we have to determine what's the shape of our data before we decide which of these we should select. The ones I'm going to focus on are the range, the interquartile range, and the standard deviation, because those are the ones that you see probably reported the most in the literature. The range is just the difference between the minimum and maximum values in the data set. The standard deviation is an average deviation of all of the values from the mean. It's an average just like the mean. And then the nice thing about the standard deviation is it's in the same units as the original data. The range, again, is the distance. It's easy to calculate, it's easy to understand, but it's highly influenced by outliers. If I have data that's all between 1 and 4 and then a 100, the range is going to go from 9, if this were a 10, to 99 just by having a single value out here. So if you have 1 or 2 unusual observations that could affect the spread measure, don't choose the range. A better measure is the interquartile range, which is basically what that box on a box and whisker plot is showing. It's showing you where the middle 50% of the data is. It's between these 2 points, the 25th percentile and the 75th percentile. So you calculate those values. It's just the points that cut off this middle center of the 50% middle of the data. So the first quartile cuts off the lower 25%. The third quartile cuts off the upper 25%. And the interquartile range describes how wide the spread of that center 50% is. So it's not influenced by extreme values because it truncates the ends of the distribution. That would be a choice that I would always make over the range unless there's a need to understand the full spread of the data. And this, of course, is the interquartile range. For a box plot, that's That's what the box is representing. This is the middle 50% of the data. The range would be from here to here. Other more mathematically sophisticated measures of variability include the standard deviation and the variance. Notice I didn't put the formula up here for those of you who've ever calculated this by hand, which I had to do in undergraduate stats. It's terrible. Just know that the standard deviation is it's probably the most useful, in my opinion, measure of variability because it's an average. What is the average distance between data points in my sample from their mean? And the average distance is given to me in the original units of the data. So if I'm talking about distance traveled, and I want to talk about the standard deviation, I can say, on average, individuals traveled 100 feet with a standard deviation of 10 feet. So what that means is the center, the average of the distance was at 10, and the way that individuals deviated around it was an average of about 10 feet in either direction. The variance is simply the square of the standard deviation. We like that for its mathematical properties and its physical interpretation, similar to what the means interpretation was in terms of being a fulcrum. The variance has a similar interpretation. It's harder to think about, though, or visualize because it's a squared. But we tend to prefer reporting the standard deviation with the mean because it's much more interpretable. And, of course, shapes. There are many different ways of describing the shape with words. This is a normal distribution. This is a bell-shaped curve. It's symmetric. It's unimodal. This is not bell-shaped. This is what's called a skewed distribution. It has positive skewness or right skewness because it looks like someone took that and stretched that right tail out in the positive direction. This is a skewed distribution. It's a left skewed or a negatively skewed distribution. It's also bimodal. If I saw this, it would immediately raise a warning to me that there are two populations here, because there's a population here and there's a population here. But I've lumped them into one in order to describe them. So a good example of this would be analytic scores on the GRE, the exam that you are required to take to get into graduate schools. Analytic scores for people who are going in, and analytic, by the way, measures kind of the math component. Analytic scores for people who are applying to engineering programs, people who are applying to, I hate to make this distinguished, no offense to anyone who's ever gone in the arts, because there are people who are in the arts who are strong in math, but in general, they're choosing the arts because they're not, that's what they like. They don't like the math. I have a daughter like that. So they're down here. So we're going to have some overlap in these two, right? You're going to have weak engineering students, and you're going to have strong arts students. But their average, their central tendency between the two subpopulations is showing up here. And that's important to visualize if you have data, because if you think you have one population, but you see this pattern, it may indicate that you have more than one. And it's important to investigate. Lots of different ways of visualizing shapes. This is what's called a bathtub-shaped distribution, which means you have high density on both low and high values and very little in the middle. Again, bimodal, very skewed, nice and symmetric. So these are all words that we use to describe the behavior of our numeric data. With the few minutes that we have left, I want to give you a brief introduction to RStudio. If you have a laptop, I would encourage you, if you're going to come next time, to bring it with RStudio downloaded on it. It's very easy to download. It's secure. It's not going to give you any viruses. RStudio is what's called an IDE, an Integrated Development Environment, and it's very nice because it provides an opportunity for the average user to program and do statistical analyses for free. And the graphics are top-notch. And I had a few of you that said you were familiar with RStudio. Have you used it for analyses or programming or graphics? Are you happy with it? Okay, good. I'm happy with it. I'm actually more familiar with the programming language R that it's based on, that it uses. But this is a nice packaged version of R that gives you a better, more user-friendly interface. The other nice thing about it is because it is open source, R is open source, which means that if instead of putting data into a black box and not knowing what the box is doing, you get out you are able to see inside the box. You can take the lid off and you can see what the box is doing. So you can see the code if you're interested in knowing what the code is doing. I've given a link on the slides, and I will email the slides out to the distribution list as soon as we get done today. That way you can have a copy or visit the links in your free time. It's just rstudio.com. You can look at some of the interface here. It says download a 45-day evaluation, but that's just the server pro. What you want to do is, I think it's moved it. Download RStudio. It'll be on the main page. You may have to go back. Download RStudio, which if you've never used R, it requires you to download that programming language R as well. So it will show you here, run RStudio on your desktop, which is what you want to do. Download RStudio desktop, and it will say here on this final launching screen, RStudio requires you to have R on your machine. If you've never downloaded R, do it here. And it takes 3 minutes. You just have to hit yes, 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 I accept, run, and it will create, let me escape out of that. It will create an icon on your desktop. Now, this is a Windows machine, but it's also available for Mac or Unix machines. But it will have an icon. This is the programming language. In addition to that, you need to download, once you've done that, RStudio through these installers here, whether you have Windows, Mac. I don't even know what Ubuntu is. I mean, I've heard of it, but I don't know what it is. Fedora and Red Hat, whatever those things are. But you probably want one of these depending on your laptop. Download that. And I can't do it on this machine. I'm going to have IT come and do it for me this week to make sure that we can actually work in RStudio, because next week we are going to cover an introduction to hypothesis testing. We're going to talk a little bit about experimental design because we have to acknowledge the strengths and weaknesses of each of the type of designs and contexts that generate data before we can start to work with the data. But I will be doing some simple demonstrations of analyses. If I can get the code all pre-written, I will email it out so you can have the code and load it in as opposed to typing along with me. I can't promise I'll have that done, but we'll see if I can get it done before then. I'll try. And if you're interested in learning how to do some basic graphing or some basic descriptive statistics, calculating means, ranges, confidence intervals, doing a t-test, doing a correlation or a simple linear regression, I will show you how to do that in RStudio in the next 3 weeks. Okay? Any questions? None? Any comments? Okay, well, we ended right on time. I'm glad I removed a lot of material from today so we didn't go over. I hope to see you all next week. I'll be sending out the PowerPoint shortly. Thank you. Make sure that if you need your parking validated, you come see me. You're welcome. I'm glad. Thank you. Parking. Where did you guys come from? Children's First? Yep. Okay. I'm not sure where. You just give that to the you got three parts. Where did you park? On campus? On Hemingway? Okay. You didn't have to have like a ticket or anything for parking? Hopefully you didn't get a parking ticket for parking there without a pass. I don't know. Yeah, so you can actually park next week if you're coming in Olathe 2. So in the link that I sent last night.
Yeah, I got that, but I was coming from home.
So you just were there. I think you should be okay. If you got a parking ticket, let me know, and then we'll try to get it waived. And then have you park in public parking, and when you park in the garages, Olathe 2, or in Cambridge, kind of where the patients for the hospital park, bring your ticket, I can validate it, you won't have to pay for parking. Okay?